All right, to all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after this journal club. The information that's contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSN or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content, which is provided as is and without warranties. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customer care at gotowebinar.com. Please ensure that this is done to receive your statement of credit. And please disregard my son falling asleep here. If you don't receive the follow-up email or have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the questions and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. Dr. Neha Raukar is a practicing physician in both sports medicine and emergency medicine and is active in education, clinical medicine, legislation, and research. Her sideline experience spans the breadth from high school, collegiate, and Olympic athletes. She has been the recipient for grants exploring innovations in sports medicine and enjoys creating national policies that protect the health and safety of athletes at all levels. An associate professor at the Mayo Clinic, her research interests include injuries and life-threatening diseases in athletes and is dedicated to educating fellow healthcare providers as it relates to these topics. All right, and I'll have you take it away.
All right, thanks so much, Dr. Henne. Good to see you all. If you have any questions, feel free to put it in the chat or even just write them down and save them for the end. All right, so we'll get started. We're going to talk about a structured approach to the collapsed athlete. This is one of those halo events, something that's high acuity, but doesn't happen very often, low occurrence rate. Let's see, is this working? Okay, I have no financial disclosures. I do write policies and work with different organizations, and so you'll hear some of their thoughts, and I will put them in our talk. So when we think about the collapsed athlete, let's see if I can get this to work. I want you to put yourself in this room. I want you to put yourself on this field. I want you to put yourself on the sideline. I want you to smell that unique combination of sweat and popcorn. I want you to hear the sounds of the whistles, the crowd. And I want you to transition from excitement to horror as you watch Hank Gathers collapse on the court. This is a scary moment, right? And it's something that we need to put ourselves in cognitively every now and then so we can rehearse what we're going to do when this happens. Because it's not really a matter of if, it's really a matter of when in our career we're going to have to respond in this situation. So I wanted to propose to you this algorithm, and it's aligned with ACLS and BLS, but it's a little bit more detailed and tailored to what happens to athletes. So you have the collapsed athlete. You're going to call for help and an AED. We're going to do a jaw thrust, which will take care of both airway and breathing, and we're going to go into each of these in great detail. We're going to check a pulse and start compressions, and when we get the AEDs, we're going to analyze it. So let's go through this in some detail, and let's get rid of a lot of the myths that we have heard. But first, I want you to think about how many of you have had to deal with a collapsed athlete? How many of you have had to deal with an almost collapsed athlete with or without a pulse? And try to remember how you felt. And if you want, put it in the chat if you had to deal with this and what you had to go through, what you cognitively went through. So the objectives are for us to understand your role as a sideline provider in reducing preventable deaths, practicing maneuvers that will improve outcomes in collapsed athletes. And then we're going to sort of synthesize our own algorithm to approach the collapsed athlete, tailored to the athlete. So before you can create any kind of algorithm, you have to kind of know what causes collapse in the first place. And then knowing what has happened can inform what you're going to do. So when we look at the chart here, we'll see that confirmed or presumed cardiovascular disease is the #1 cause of collapse in the majority of collapsed cases. Then we have trauma and sickle cell trait and heat stroke. So these are the things we're going to talk about. We also have drugs and suicide, but on field, the things we worry about are cardiovascular disease and trauma and sickle cell trait and heat. So let's talk about those. And let me just say, we do a pre-participation exam in these athletes, and it doesn't help as much as we had hoped it would. It doesn't really help identify who's at risk for collapse. So the goal, and when I wear my emergency medicine hat, the goal is to how do I approach this undifferentiated collapse? I don't know why they fell, but I have to be able to triage in my head the most serious causes and the most time-dependent causes and manage those first. So we think about things in the way we've always learned them, and that's how we remember. So the things that matter that we have always been taught are head, heat, and heart, and then trauma. And so let's keep that framework in our head and build on that. So first, we're going to talk about the heart. When we talk about pulseless collapse or sudden cardiac death / arrest, because sometimes they are resuscitated, let's think about the epidemiology. So the incidence of sudden cardiac death is about 1 in 50,000 people per year in college athletes. And in high school athletes, it's a little higher, 1 in 50 to 80,000 athletes per year, because they're just more undifferentiated and things haven't been recognized yet. The subgroups at higher risk are men, of course, more than women, because of their genetic makeup. Basketball players, when we think about the sport that's at highest risk, it's actually basketball players, where you have 1 in 2,000 athletes. And then when we think about this from a racial perspective, people of African American descent or of African descent, so 1 in 20 to 1 in about 70,000. So how do we put this together? The highest risk athlete is the male Black basketball player with the rate of about 1 in 3,000 collapses. So if you think about that, over your career, if you cover basketball, you will have a collapse just by odds, just playing the odds. So let's go dig a little deeper. When we think of sudden cardiac death, that we sort of categorize this into one of 3 categories. It could be structural disease, so hypertrophic cardiomyopathy, congenital coronary anomalies, all of these structural things. It can be acquired things, myocarditis or trauma or toxicity or even environmental things. And it could be underlying electrical causes like WPW or long QT syndrome or Brugada syndrome. The one thing that all of these different categories have in common is that on the field or on the court, they all deteriorate to pulseless VFib or VTAC. They are pulseless. And so we can sit there and really think about what was the cause of this collapse. When you're on the field, it does not matter. There is one thing to manage, and that is the pulseless VFib and VTAC, because all of these problems deteriorate into that. So let's talk about the most common ones of these cardiac diseases. So the one that we hear the most about is hypertrophic cardiomyopathy. This is something that we are all very well versed in, and this is the story of Wes Leonard. He had hit the game-winning shot of his conference basketball game. He got lifted up on his teammates' shoulders, and then he collapsed and then died on the court. So what he had was hypertrophic cardiomyopathy, and this is the most common. And what it is at its heart, no pun intended, is an asymmetric thickening of the septum. So you see in the first one, the septum is symmetric and thin all the way down. And here you have, in the second image, you have an asymmetric thickening. And what happens is when the heart contracts, the outflow tract is blocked. This leads to scarring of the ventricle, which later leads to a nidus for an arrhythmia, which later leads to pulseless VFib and VTAC. It takes some time around high school or college age to first be recognized. The next one is an anomalous coronary artery. This is the story, the most famous story, is that of Pistol Pete, who was one of the greatest point guards in NBA history. He collapsed and died at the age of 40 playing pickup basketball. So this is the classic story of a patient who has gone through all of these workups for chest pain, but they just couldn't find the reason. They couldn't find the source. And the reason is because the coronary artery is taking off from the aorta, but the only way to see that is by cardiac CT or coronary MRI. And so when your left main coronary artery, that's the vessel that perfuses your left ventricle, and it gets blood to the heart, if that gets compressed between the aortic and pulmonic valve, that part of the ventricle is not getting any blood. So it has periods of ischemia. Granted, there are seconds or microseconds, but over a lifetime, this also leads to scar tissue and a nidus for arrhythmia. Prolonged QT is the story of Dana Vollmer, whose parents showed up with an AED to every practice and every meet. This is a channelopathy, and it can be either genetic or it can be acquired, like with medications. A lot of the medications that kids are on these days prolong the QT interval. And so this just means that it takes a long time for the heart to become repolarized. And so while it's taking this really long time to repolarize, if you get some kind of stimulus, and the one that we classically learn is commotio cordis, we sort of mix that together. But if you get some stimulus during this prolonged QT period, you will deteriorate into VFib and VTAC. So here's commotio cordis. Watch the player. He got kicked. And what we classically learn is that you have a dense projectile that's coming at you at 30 to 50 miles an hour. It hits a very pliable chest wall, and it hits it during this exact period, and it is during the upstroke of the T wave on the ECG. It's during the ventricular repolarization phase. And while the ventricle is repolarizing, just like in prolonged QT, you have this dense, small object that hits the chest just at the right moment, and that will make the electricity like get a little confused, as you see down here, and all of a sudden you end up in VFib and VTAC. Myocarditis has been more interesting lately because of COVID and the vaccine and all the controversy surrounding that. So this has become quite a topic of conversation. It can occur post-viral infection. We always think about it. But it can also be an autoimmune issue. And so what you have are inflammatory changes to the muscle of the heart. And again, the muscle doesn't work as well as it should. And so then you start getting scar tissue, and again, you precipitate arrhythmias. So let's talk about what happens to the heart when you have VFib and VTAC. And so this is an echo, a bedside echo. Let me show you here. Here you have a normal heart. I want you to just see how beautiful it's squeezing, how organized it looks, how it's getting the blood out of the heart, right? Let's see if I can get the next one. Oops. And here is, okay, let me pause that one. Here is one that's in VFib and VTAC. See? We call it like a ball of snakes. Nothing's happening. It's completely disorganized. The blood can't go out. The person collapses because they're not getting any cardiac output. So there's no blood going to the brain. The person collapses. And the heart is just like this bag of worms. Nothing's happening. So we talk about out of hospital survival. And the important point to know is that every minute delay to defibrillation leads to a 10% decrease in survival. 10% per minute. So every minute actually does count. And so this is really important. Like my goal today is to get rid of your cognitive burden when you're running out onto the court. I want you to feel very automatic. And so if a person collapses, your job is to assume that it's the heart, because this is the one place where you have no time to waste. And you have to take this heart from a non-perfusing rhythm to a perfusing rhythm. And the way to do it is to shock them. And until you can shock them, you're going to perfuse the body with your own compressions. Here's what the public knows about sudden cardiac arrest and survival rates. Somebody actually did a study and looked at all of these TV shows, ER, MASH, House, and Chicago Med, and looked at the survival rates after a cardiac arrest. And their survival rates were closer to 80%. But in real life, the survival rate is with out-of-hospital CPR is about 10%. And if you make it to a hospital, it's about 20%. And so the goal is to get them resuscitated right there on the field. So let's go back to our algorithm. We have a collapsed athlete. You're going to call for help. The jaw thrust is your airway. It also takes care of breathing, and we're going to go into why. We're going to start compressions and check a pulse, and then start compressions if you need to. Attach the AED pads and analyze. So it's not all three letters. It's not ABC. It's A, B, C, and then AED. Let's go into that. First, let's talk about the jaw thrust. So the jaw thrust is the way to open the airway. In a young person, if you are able to open up their airway, you will give them 8 minutes of oxygen without doing any breaths. 8 minutes is more than enough time. You don't need to breathe. All you need to do is do a jaw thrust. So let's just talk about how to do this, and let's do it to ourselves, which is not as useful, but what I want you to do is just get the landmarks, and then when you're around somebody like a loved one or each other, do it to each other. So what you would do to somebody else is you would put your thumb just superior to the angle of the mandible. So it's right below your earlobe, and if you just walk down your jaw, you'll feel the angle of the mandible. Just behind that is a squishy spot that's kind of painful if you push on it. That's where you're going to put your thumb, in that painful spot. And then you're going to put your fingers around your jaw. It's easier if you think about somebody else. And then you're going to distract the mandible forwards. Now, there's a couple of reasons you do this. One, like I said, it's to open the airway. But if I have an altered, in the emergency department, if I have an altered patient or somebody who's seizing or somebody who's drunk and I don't know if they're breathing very well, if I do this jaw thrust, it elicits a lot of pain, as you can tell. By eliciting pain, they will grunt or gasp or something, and they will tell me that they are with it. That is enough. If they can feel the pain, then I know I don't have to go on to CPR and AED and so on. But if you're doing a jaw thrust on somebody and they do not gasp or tell you to go away or move your hand away or grunt or something, then that's your internal threshold to be concerned. You did a jaw thrust, nothing happened. Okay, you are now committed to start going down this algorithm. And everybody in the room or everybody around you knows, okay, they didn't really respond to the jaw thrust. It's time to move on. So here's another view of it, but I want to show you this video because it shows you, I said to you that if you open the jaw, if you do a jaw thrust well, you will give them 8 minutes of oxygen. Let me just show you what happens. I'll play this video a couple of times because it's really, really fascinating. So here you're doing a somewhat terrible jaw thrust, and here, see that airway opens up? See that lighter gray? That's the airway. See how much that opens up? I don't know if you can see my arrow, my pointer. Maybe I'll do it again. Okay, so if you do it again. Okay, that's a little bit. And then if they do it again, there's a nice, big, beautiful airway. Okay. So if we were in real life, I would have you practice on each other, but we'll save that for next time. So now we have our algorithm. You have your airway and you did your breathing because you gave them 8 minutes of oxygen. Now we're going to check a pulse and do compressions. Let's talk about that. So the C is circulation and compressions. So you're going to feel for a pulse and compressions. Now, I've been on a lot of sidelines through the years, and what I notice people doing is feeling for a radial pulse. And there are pulses all over the body. But if you are in an emergency situation, the pulse I want you to feel for is the carotid. That one, That the carotid pulse is the one that you lose with a systolic blood pressure of 60. You lose the radial pulse with a systolic blood pressure of 80. And so it's not the most sensitive measure. The most sensitive is the carotid. And how wonderful. Your hands just did a modified jaw thrust. You were just at the neck. So now you don't have to move your fingers very far to find out how the carotid pulse is doing. So for a moment, take your hand and feel for your carotid pulse. When we think about compressions, so now you felt for a carotid pulse and you didn't feel one. So now you have no response to your airway maneuver and you had no response, no palpation of a pulse. So now you're going to move to compressions. Performing CPR, we all know this, optimizes blood flow to the major organs. You had positive oxygenation with your jaw thrust, so now you want that oxygen to be transported around the body. And so we have here the cardiac output. And I want you to notice that with compressions, the cardiac output drops dramatically when you take a pause. And so we try to have these, we try to do CPR with very little pauses, and it's tiring, it's exhausting. They did a study on NFL athletes, and even they could only do 2 minutes of really good CPR before their quality of CPR went down. So while you're doing CPR, you have to have in your mind, or while you're leading this, you have to have in your mind who's going to take over for whoever is doing CPR right now. There's lots of songs that will help you keep the rate of CPR appropriate. There's one in every genre, so you can Google that if you like. So I'm hoping you all found your carotid pulse. So how much do seconds count? So what we said, with high quality CPR, you have a 4% decrease in survival for every minute. With AEDs, you have a 10% decrease. So CPR is actually very effective and AED is just better. So let's go over some things about the AED use. We can use adult pads for anybody over 8 years old, but a lot of people don't have pediatric pads in their kit, and that's fine. If you don't have pediatric pads, you can put adult pads on the front and back of the child. In general, the pad placement is the right one goes below your collarbone and the left one goes below your breast. A couple of pearls. The person does not need to be completely dry. It doesn't do anything to the machine. They have to just be dry enough to get good contact of the pads on the person. You don't need to remove jewelry. Just try to place the pad away from the jewelry. There's no interference from tattoos. If you see the markings of a pacemaker, and you can feel that, right? It's big. You'll see a deformity and you'll feel a hard metal thing underneath their skin. Don't put it on top of that. Try to put it about an inch away if you can. If you see a medicine patch, remove it, or just again, don't put it on top of that. You can use an AED in young children. Like I said, the position should be front back if you don't have pediatric pads. And of course, you can do this in pregnant patients. This should not be delayed for pregnant patients. So let's talk about some barriers that you meet when you are on a field. So if you have a helmet and pads, you can do your jaw thrust through the helmet, and then you can do your pulse check, and you can start compressions if you need to, maintaining C-spine. You can cut their shirt and put the AED on. If they're face down, you can check their airway or open their airway, check for breathing. You can check for a pulse, and then you can roll them and start compressions and an AED. And if you have a spine injury, it's the same thing, just do it with spinal precautions. So let's review the pulseless patient. You have a collapsed athlete, you've called for help, you had opened the airway, you've given them 8 minutes of oxygen, so you don't have to breathe again. You can do this on helmeted athletes. You can look for an obstruction. You're going to consider the C-spine given the mechanism. You can check a pulse and start compressions. You can do this both on helmeted athletes. You may have to roll them depending on how they collapsed. And in cases, you will again consider the C-spine. And you can do the AED. You can just cut or move clothing to get the AED pads on appropriately. So I'm going to play this again because I really want you to think through. This is the mental model, right? You have to think through, visualize success. You have to visualize what you would do in this situation. So let me play this again. Okay. This is cheating a little bit because the camera does focus in on who is collapsing, and you're not going to know which one collapses, but that's okay. This is always televised. It always generates significant media attention. And so, and we know the incidence of sudden cardiac death is higher in athletes compared to our non-athletic counterparts. And so it's just something that we have to be very comfortable-ish with doing. All right. So I did mention that we're staying true to ACLS, but now that you've given them open their airway, you don't need to breathe for them. It's compression only CPR. So let's say you have a patient or an athlete who collapses and you did your modified jaw thrust, they maybe grimaced, or you check their pulse and you have a pulse, but you still have a collapsed person in front of you. So where does our mental model take us next? Well, let's think about the differential again. So we have a collapsed athlete with a pulse. We're thinking heat stroke, given the right conditions, sickle cell crisis, and we will talk about that, trauma, or a head injury. We can also think of hypoglycemia or seizures. The hypoglycemics, you will know, or you should know, the members of your team who are diabetic and are at risk for that. And same with seizures. You should know, or you'll have an idea which members of your team have a seizure disorder. All right, so putting this back into a way we can remember it, let's do heat next. So this is Jordan McNair and Corey Stringer, both who collapsed and suffered the effects of heat stroke. And the point I want to bring up here is it is really hard to identify sometimes. Sometimes you just have no idea, is this cardiac or is this heat? But if you run through your algorithm, then you will be able to figure this out. There's a lot of controversy, I don't know why, about the different cooling rates and which ways we need to cool people. The best way, looking at this from Doug Casa's group, the best way to cool somebody has always been ice water immersion or cold water immersion, one or the other. Ice water is obviously better. But without that, the taco or the tart method is fine. This is exertional heat stroke is completely preventable. It requires immediate recognition. It should require a core temperature, and we should be doing that. Sometimes we don't for a variety of not great reasons, but sometimes we don't. But the treatment is cold water immersion. I am working on a national movement to get EMS to also understand that the patients need to be dunked at the sideline and not be brought to an emergency department. The standard of care should be to let these patients stay at the sideline until they are dunked. So just a few rules about dunking. They want the water temperature to be between 35 and 58 degrees. Some people use a rectal probe to know when to get the person out of the water, and you cool them down to 104 degrees Fahrenheit versus time. When their mental status improves, they take them out. If you choose to do that and you take them out of the tub, just still keep an eye on them because as they warm back up, they may need to be redunked. Okay, this is similar to heat stroke, so I'm going to put this here. It's exercise collapse associated with sickle cell trait, ECAST. So let's just talk for a minute about sickle cell trait. We don't learn enough about this in school. So let me put this, or we don't learn about it in a way that's practical. At least I did not. So let me put this in a way that's practical. So what you have is you have an abnormal sickle beta hemoglobin that's inherited from one parent, because this is trait. So this is inherited from one parent, which combines with the normal beta chain from the other parent. And this leads to your hemoglobin. You have normal hemoglobins and you have sickle hemoglobins. So in each red cell, you have some normal and some that have the potential to sickle. Sickle cell disease and sickle cell trait, as you will recall, impacts African Americans at ridiculously disproportionate rates, and that's because it's evolutionary. Sickle cell trait helps protect you against malaria. So in parts of the world where there is malaria, sickle cell trait people lived longer, and so this is why it's survived through the generations. 8% of African Americans have sickle cell trait, so they have it from one parent, and 8% is like 1 in 13 live births. And 1 out of 365 African Americans have sickle cell disease. So trait is pretty common, all right? So what happens? When you have sickle cell trait, there are 4 things that lead those cells, those red blood cells, to sickle. And if you have enough of the red cells in sickle cell trait patients sickling, that will lead to collapse. So what are the 4 things? Local hypoxia, acidosis, hyperthermia or increased temperature, and red cell dehydration. These are the exact 4 things that happen at a local level when you are exercising. Local hypoxia, acidosis from lactic acidosis, hyperthermia because you're exercising muscle, and red cell dehydration. So it's not shocking to learn that sickle cell trait is something that the NCAA is screening for, and we should be, right? We should be aware who has sickle cell trait because they are at high risk of collapsing because they are put under these conditions. And so what do you do? Well, it's local hypoxia and hyperthermia. So if you have oxygen, great, give them some oxygen. If you don't, that's okay. Consider dunking them to help cool them and consider hydrating them. If they are conscious, oral hydration is great. Start hydrating them, reverse their hypoxia and reverse their hyperthermia. Hydrating them will also reverse their lactic acidosis or help to reverse their acidosis. Okay, so we did a little heart and we did a little heat. Let's talk about the head now. So just to put us back in a frame of mind, we're talking about the collapsed athlete or the athlete who collapsed who has a pulse. Okay, and you've ruled out head things by your ABCs and you've ruled out heat. Let's go to the head. No one knows this better than an athletic trainer. No one. But let's review it anyway. The question that always comes up is, who do you send to the emergency department? And so in the emergency department, we have 2 sets of rules that we use to identify, because it's not who to send to the emergency department, it's who do we image, right? And so we have a couple of sets of rules that we sort of rely on. One is the Canadian head CT rules, and they go like this. If your GCS is less than 15, 2 hours after the event, and we watch them for 2 hours on the sideline. If you palpate them and you suspect that there's an open fracture or a depressed fracture, so you're feeling it and you feel like crepitus, you're going to send that. I don't need to tell you to send that. If you have signs of basilar skull fracture, and we'll go over those in 1 second. If you have 2 or more episodes of vomiting, this is always a point of contention. Is it 1? Is it 2? I would say the rules say 2 or more episodes of vomiting. If you're more than 65, if you're amnestic more than 30 minutes, and if you had a dangerous mechanism, which I would say as sideline personnel, our patients all have a dangerous mechanism, or the great majority do. And then in kids, we have similar rules. Are they altered? Do they have a GCS of 14? And again, the signs of basilar skull fracture, vomiting, loss of consciousness, or a headache. Those should come in. The signs of basilar skull fracture that I just want to review with you is raccoon eyes. This is when you have both eyes are have a hematoma. That's a sign of a basilar skull fracture. You're not looking at eardrums on the sideline. I never have. But if behind the ear you see this battle sign, it's post-auricular ecchymosis. Or if you see that they're running clear fluid out of their nose and they weren't sniffling before, those are all signs of a potential basilar skull fracture. And those should be sent to the emergency department. So we talked about head, heat, and heart. I want to take a few minutes. I don't want to keep you too long. We're going to take a few minutes and just to talk a little bit about trauma. So we had the patient with the pulse, and now we know that they had some trauma. So let's look at their airway. We're looking for an obstruction, and we're going to look at their C-spine. So here's your algorithm. Airway, which opens up the breathing. C is for checking the carotid and compressions if you need to, but here you're not needing to. So now you're going to go back. Airway with the twist, keeping their C-spine immobile and compressing any bleeding. So let me just show you a couple of examples of bleeding. So we're looking at facial trauma here, right? And here, with the image here, the CT image, is showing bleeding that you can't see, but it's in the soft tissues, that there's internal bleeding that's compressing the black airway, as you see. So jaw thrust with a twist. We're protecting here the cervical spine. And the reason I want to bring this up is because 20% of the time when you have facial trauma, you're going to have some C-spine associated injury. And so when somebody has facial trauma, you have to be very protective of their C-spine. And that's the one time to really hold spinal precautions. And what we saw in the image was laryngeal trauma. So here's your larynx, and you can see that if you have any trauma to the larynx, that's going to affect the patency of your airway. And sometimes the only clue is a little ecchymosis or hematoma on the anterior aspect of their neck. And so they don't always have a hoarse voice. They often do, but not always. And so if you witness this, it looks so benign, right? Oh, look, you have a bruise on your neck. It can be such a big deal. And it's actually a real big emergency when they come to the emergency department because they've had some time to bleed internally. And so now they're compressing or invading their airway. And so this gets bad really quick. So if you suspect laryngeal trauma, nobody will ever fault you for sending that to the emergency department to see if it's real. All right, let's talk about controlling hemorrhage. So this is under circulation, and we have tools externally to help us. If you have external bleeding, we have some tools to help us. And if you have internal bleeding, without an ultrasound and without knowing for sure, the rule should be to transport that. So let's think about the tools that we have for controlling external bleeding. The first and most important tool is compression. That is always the right answer, but there are ways to make compression more effective, and that is by putting some vasoconstrictive agent on a 4x4. My agent of choice is Afrin. I carry a ton of Afrin when I cover any event. It's a natural, very strong, not natural, it's an over-the-counter, very strong vasoconstrictor. And so you can also use lidocaine with epi, squirt it on a gauze, and unapologetically put it everywhere. And that will help to control it. If you put enough pressure and enough Afrin, you will control bleeding. Whether it's even on the scalp, you can put it on the tongue, anywhere that there is bleeding, I would recommend that. If that doesn't work, looking at the diagram, the next thing to consider is staples. You don't have to do a pretty job. You just need the skin edges to come together to get some compression. There's also the Stop the Bleed kit, which you guys all know much more about than anybody else. So think about in your kits, what do you carry and what do you need? Do you need to get some Afrin? Do you need to get some lidocaine with epinephrine? So we talked about the things that matter, head, heat, heart, and some trauma. We talked about heat will kill, so consider the temperature and dunking them. The facial trauma, think about the ABCs and doing it with spinal precautions in mind. If you have abdominal or chest trauma, if you have external signs of bleeding, we can compress that and manage it with medications. We can do a whole talk another time about ultrasound and the FAST exam if you have an ultrasound. For the head, we talked about the CT rules. Consider internal versus external bleeding. Consider spinal precautions. So now let's put this together. I am a big fan of the medical timeout before every practice and especially before every game. Just so I know for myself as a sideline provider, who knows CPR, who's going to get all the equipment, because I can't do everything. Who's going to call EMS and flag them and bring them to the scene? I'm terrible at directions. Nobody wants me calling EMS. Who takes care of the rest of the team, and can the rest of the team help? And who dissuades all the nosy people who are just looking and want to get involved? The other thing I would say is the value of teamwork, right? Like the emergency action plan and the medical timeout, the value of teamwork can't be understated or can't be overstated, right? So this is the dream team. And to help this team prepare for the Olympics, the NCAA put together their squad of the best players, and they played this dream team of American Olympic athletes. And the NCAA team won because this team of awesome basketball players had never played together. So they just didn't know how to work together. And this is the point of the EAP. We have to learn how to work together when this situation comes up. So make sure you go over your emergency action plan. So let me just show you this one more time. So you have your collapsed athlete, you've called for help and gotten an AED. You do your airway, they have no response. So you go on to check the pulse and there's no response. So you've just started compressions, and hopefully soon an AED arrives. But until the AED arrives, about every 2 minutes, you're switching the person who's doing compressions because compressions are hard. And then you attach the pads and analyze. If the thing says no shock advised, that means it is not VFib or VTAC, and you go back to doing compressions. Many of these things, initially it'll say no shock advised, and then the rhythm will deteriorate enough where then it is advised. And some things, it will give the shock like commotio cordis. That actually takes a couple of shocks. So they still won't be revived. So you'll have to do it a couple of times. And you'll just go back to CPR. And then when the time comes again, you'll reanalyze and do it again. If you have a collapsed athlete with a pulse, you have in your head, heat, and heart. And the things to think about for the head, does this person need further imaging? For heat, we're going to dunk them. We're going to use a temperature probe if you have one, and you are going to delay transport. You're also going to consider a sickle cell patient, so you're going to give them oxygen if you have it, IV or oral fluids, and dunk them if you have to. And you're going to keep sugar, glucose levels if you have a diabetic athlete. In trauma, you're going to control the bleeding. If it's internal, you're going to transport them. If it's external, you're going to use your tools. In facial trauma, you're going to look at the airway for any obstruction. The most common thing that obstructs the airway is your tongue because it's already in your airway. And so we're going to look for that and make sure that it's not obstructing. And we're going to keep the C-spine in mind. And if there's any bleeding, we're going to compress it. I don't know if you want me to go over the questions. Do you want me to do the questions here? But if not, I'm happy to take questions from you guys. Thank you so much.
All right, the first question here is coming from Audrey, and she says, I just want to ensure that I'm doing it correctly. Doing a jaw thrust without breaths or any other action will give 8 minutes of oxygen.
Yes, that's true. Yes, if you do a jaw thrust, you are passively oxygenating them, especially if they're young, you have 8 minutes. You don't have to do breaths. The whole country is moving away from giving breaths during CPR anyway, so yes, you will be fine.
All right, the next question comes from Nadine, and she says, often jaw thrusts don't stay in position. So would you recommend doing that with 2 people?
Yeah, so I'm not, I have very small hands and my hands are actually, I have no grip strength. I'm not going to live very long, right? I heard that that's tied to longevity. So yes, I would have a stronger person. You can have a stronger person hold the jaw in place, like after you do your jaw thrust, you can have somebody else hold it in place, or because you have 2 people switching on and off CPR compressions, or a couple of people, one of them can hold it as well. Yeah. Mine holds though. Once you do it and you get that nice deep gasp, as you saw on the X-ray, once you get that nice deep gasp, it can fall and you still have a few minutes. So if you're alone, you can open it, do your compressions, and then open it again periodically.
Okay, the next question comes from Audrey. I've had people attempt to prevent from ice tub immersion with suspected heat stroke because it will send them into shock.
Yeah,
What are your pearls for explaining to them that this is the correct treatment? And she says that one time this happened with EMS.
yeah, this happens all the time. I totally agree. And so Doug Casa went back to his heat lab, and here's what I tell EMS, because they always tell me that too. Oh, this person's going to go into shock, which doesn't even make a whole lot of sense, right? But in heat stroke, no one's going to know more about this than the athletic trainer. And so what I tell them is all those studies that say that that person goes into shock were normal euthermic people. When you are actually hyperthermic, you don't go into shock. That's the problem. You don't dilate enough to sweat out the heat, and so you're not going to go into shock. So all those studies, all these ideas that they're going to go into shock is all from people, all that was done in people with normal temperature. If you put a normal temperature person in cold water, yes, they're going to be very cold. That makes sense. But if you put a hyperthermic person in cold water, their blood pressure will not drop. I hope that answers your question. I hope that's convincing enough.
All right, fantastic.
I have the questions, the multiple choice questions, if you want me to do them here. Otherwise, I don't have to.
Sure, we can certainly go through those.
Okay. All right. I won't give the answers, but I want you to think about the questions. How about that? But we went through all of them. I made sure. Oh, I stopped sharing. Hold on.
And some of the attendees are requesting that we do go through the questions.
Okay, fine. Do you see my screen?
Yes.
Yeah. Okay, question 1. Multiple choice. What are the most common non-perfusing arrhythmias in athletes experiencing cardiac collapse? What does every rhythm deteriorate to? Am I saying the answer? Probably. The answer is VFib and VTach, right? Every rhythm degenerates into VFib and VTach eventually, and that's the shockable rhythm. Okay. True or false? The primary objective in managing cardiac collapse in an athlete is to establish a perfusing rhythm as quickly as possible. True. That's what you're trying to do. That's the whole point of CPR, and that's the whole point of the AED. Get them back into a perfusing rhythm. You remember those echoes, those bedside echoes that we showed of the heart. One's beating really well and one's not beating. It's a bag of worms. Fill in the blank. The time-sensitive goal for defibrillation, so using the AED, is within blank to blank minutes of cardiac collapse. Oh, maybe I didn't say this. To ensure a good neural outcome. It's 3 to 5. Because remember, you drop 10% your survival rate, 10% per minute. So you have 3 to 5 minutes to ensure a good neurologic outcome. That's what they say in the literature, but you'll see lots of miracles where people leave the hospital in great neuro intact after many, many minutes of downtime. But the answer on any test is always 3 to 5 minutes. All right. Question 4, multiple choice. The modified jaw thrust is used to perform rapid defibrillation. That doesn't even make any sense. Reduce airway obstruction and assess consciousness. Right, because it's a painful maneuver. Palpate the carotid pulse. No, that comes next. Control hemorrhage. No, that has nothing to do with hemorrhage. So it's reduce airway obstruction and assess consciousness because it's a very painful procedure. So I really want you to do this to a loved one or somebody you don't love very much and just see how painful it is. All right, true or false? The presence of gasping respirations in an athlete during collapse should be interpreted as a sign of effective breathing effort. If I'm gasping for air, that is not effective breathing. So this is false. You're gasping, right? It's the opposite of effective. Which pulse is recommended for assessment during a cardiac collapse scenario in an athlete? Radial, so your wrist, femoral in your groin, carotid in your neck, brachial in your arm. The answer is carotid. Your hands are already up there. Use the carotid. It's also the last pulse to disappear. So it's the best one to check for. If you're looking to see if somebody has a pulse, check the carotid. Fill in the blank. Continuous chest compression should be performed at a rate of blank to blank per minute at a depth of blank inches. I'm not sure if I said this. So chest compression should be 100 to 120 compressions per minute, but you should have known that, at a depth of 2 inches. Last question. For an athlete who has collapsed but still has a pulse, which of the following is not a primary concern? Heat stroke, so you have the collapse with a pulse. You are thinking, could this be heat stroke? Sudden cardiac arrest, well, they have a pulse, so it's not sudden cardiac arrest. Sickle cell trait related collapse that you have to consider, and a significant injury, head injury, you have to consider that. So the answer is B, sudden cardiac arrest. So we went through our objectives. Think about this, like when you're driving to work, the next time you're working, just think about your mental model. And that's how you ensure that this is more smooth for you. I'm happy to take more questions though.
All right, fantastic. And we've actually had a lot of good feedback in the comments here about going through the questions during the presentation rather than people just kind of answering them, wondering if they've gotten it correct or not. And then there was a request from an attendee, Tamina, it might be how it's pronounced. Is it possible to see the PowerPoint slide again for collapse with a pulse?
Yeah, of course. Let me see. I don't know which one, but let's see. Let me go back. Like the differential maybe? Let's see, collapse with a pulse. Let me go back, sorry. This one?
Perfect. Okay, he says thank you. And then one of our attendees, Scott, is curious if you're willing to share your contact information.
Sure. Sure, I will. How shall I do that? Well, I can just tell you my email address. It's here, I can go to the first slide. Maybe I can go to the first slide. Am I sharing my screen? Yes.
Yes.
Okay. It's my last name dot my first name at mayo.edu. So it's Raukar. Sorry if I'm making you dizzy. Yeah. So it's Raukar, Raukar dot Neha, Neha, at mayo.edu.
And Audrey asks, is there a way to articulate how to do the correct jaw thrust to prevent just barely opening the airway, like in those videos?
Yeah, so when you get it right, it actually is, you'll do it by feel. So it's you'll know you have it enough because the person's jaw is actually extruded. It's like this. And you'll feel it. It gets hard at first, and then you move it forwards, and it's actually easy. And you're like, oh, I got it. So it starts difficult, and then it gets easier. What I do, because I have such small hands, I put my thumbs on their face, on their zygomatic arch, and then I use my fingers. I put my index finger at the angle of their mandible. I can use that to hurt them as well. Like point it in their squishy spot, and then I use my other 3 fingers and I really just pull. I'm not very strong, and so that's how I do it. And I use my thumbs for leverage.
All right, fantastic. Well, certainly lots of great questions and lots of great responses, certainly. Thank you very, very much for presenting today, Dr. Raukar, and thank you to everyone for attending. Please don't hesitate. If you have any other questions, please don't hesitate to put those into the question box. And then, just like you had asked for previous speakers, that's what got us here with Dr. Raukar. Please continue to give us recommendations on speakers or topics that you want to have presented.
Thank you all so much for coming and for listening. And thanks for the great questions. I really love that. Thank you.
All right, have a great day, everyone.
Bye-bye.